rounds. It is 12 noon. Just a reminder, the meeting will be recorded today. And just another quick reminder to please answer a survey that will come to you at the end of the right after the presentation from the Department of Medicine, a brief survey on the presentation, and that would let us know that you were present today as well. Our guest speaker today comes courtesy of the Department of the Division of GIM, and we have Dr. Suzanne Morin, who's going to introduce our speaker today. Welcome, everyone, and welcome our speaker.
Thank you, Nadia. Good
afternoon. Go ahead.
Okay. So thank you. So thank you, everyone, for being here. So we're very happy today to have Dr. Stephen Hwang, who's a professor of medicine at the University of Toronto. He's the director of the MAP Center for Urban Health Solution and chair in homelessness, housing, and health at St. Michael's Hospital. He also is actually past president for the CSIM. His research program focuses on interventions to improve the health of people who are homeless and to interrupt chronic homelessness itself. Dr. Hwang is a specialist in general internal medicine who has worked for the past 3 decades as a healthcare provider for people experiencing homelessness. And I should add that his best or most important credit is that he's also married to my very good friend and colleague, Dr. Angela Chung, with whom I do bone research. So welcome, Stephen, and we're very happy you accepted to do this presentation today.
Thank you very much, Suzanne, and thanks to everyone for the opportunity to speak with you all. I'm going to just start sharing my screen here. So just 1 second while I get my slides started. And let me just start from the beginning. There, so could someone just indicate to me that my slides are sharing appropriately? You're seeing the slides? Great.
Perfect, perfect, thanks.
So I'm going to be talking with you today about improving the health and well-being of people experiencing homelessness. And I have 3 learning objectives that I'd like to share with you. So first, I'm a very practical person. I'd like to identify 4 practical tips that you can use to improve the care that you provide for hospitalized patients who are unhoused. Secondly, I'm going to hope that you can consider strategies to improve healthcare systems and your own healthcare organization to better serve patients who are homeless and marginalized. And thirdly, a learning objective is to reflect on your potential role as an advocate for structural change on the social determinants of health. So I do have a few disclosures. I received funding from CIHR and St. Michael's Hospital Foundation for research and for service program delivery. And I also received sessional payments from Inner City Health Associates for clinical care that I provide to patients at a homeless shelter in Toronto. So first, I'm going to start with a shameless plug for the research center that I'm the director of. So MAP is dedicated to creating a healthier future for all. Some MAP scientists tackle complex urban health issues with a focus on developing scalable solutions that address the social determinants of health and increase health equity. Our goal is to have real world impact, and we do that through developing intersectoral partnerships and engagement with community members, policymakers, and providers. So if you'd like to learn more about MAP, which is based at Unity Health Toronto in Toronto, you can just go to maphealth.ca. We have a number of major research themes. One, of course, is homelessness, housing, and health, which I'm going to be talking about today. We also do research and interventions in violence prevention and response, the opioid crisis and substance use, chronic disease inequities, sexually transmitted and bloodborne infections, and very importantly, children and youth to ensure that people have a healthy start in life. So I'm going to talk a little bit about the problem of homelessness in Canada. we actually know from point prevalence studies that more than 30,000 people are homeless in Canada on any given night. And we also know that if you look just at shelter users, there are approximately 129,000 people who use shelters during the course of a year. However, that number does not count the much larger number of people who are homeless but are not using shelters. Often they are couch surfing or they're sleeping on the street. So we actually know that if you ask Canadians whether or not they've been homeless in the last 5 years, as many as 2% or 500,000 individuals have experienced homelessness in the last 5 years. So it's really a significant issue in our society. We also know that there's an overrepresentation of Indigenous people in the homeless population. They make up 31% of shelter users across the country, even though they represent only 5% of the total Canadian population. So there is something that we call a typology of homelessness, where we actually look at the duration of the episode of homelessness. We define chronic homelessness as people who have been homeless for more than 6 months in the past year. Episodic homelessness is people that have had more than 3 or more episodes of homelessness in the past year, but haven't been homeless for 6 months continuously. And people who are transitionally homeless, who are often homeless for only a single isolated episode of time. Now, the reason I bring this up for this audience is that we often have a bias in our perception of who is experiencing homelessness. And that's because as internal medicine doctors, and certainly as hospital-based physicians, we see a very specific group of people who are homeless. We are more likely to see people who are chronically homeless because they are those who have the highest level of need for hospital level care. And also, just on a very experiential level, as we walk around the streets of our cities, and certainly on the streets of Montreal or any other major city in Canada, we encounter people who are visibly homeless, but this is a very small proportion of the homeless population that are actually on the streets. And so we have an overrepresentation in our minds that people who are homeless are older men who are on the street, whereas we don't see families who are living in homeless shelters. We don't see refugees who are homeless for just a few weeks or months before they move on. And we don't see youths who are typically physically quite healthy. So I just want to point out that our picture of homelessness needs to be adjusted to who's actually in the population, in addition to who we serve in the hospital. So why do people become homeless? This question comes up a lot, and I bring it up because it really is important to how we think about the issue of homelessness. We often, as physicians, think about these reasons here on this slide. We think, well, people become homeless because they have substance use problems or mental illness, because they've lost their job or lack job skills, because they don't have family supports, or maybe because that's their personal preference. But when we think at that level, we are neglecting the larger societal issues that are also causing homelessness, such as high housing costs and the lack of affordable housing in our cities, low social benefit rates, changes in the job market so that a high level of education is required for a decent paying job, the very low minimum wage that we pay many people that makes it difficult to afford housing, the lack of support systems, and the legacy of racism and colonialism in our society. So rather than saying that some of these reasons are the real reasons that people become homeless, I think it's important to recognize that those reasons on the left are individual level factors that help us understand why certain people are at higher risk of becoming homeless than others. But what these individual level factors don't explain is the structural or societal forces that determine why homelessness is so pervasive in many of our cities. And this dual explanation, this understanding that why one person is more at higher risk of becoming homeless does not necessarily explain why do we have the problem of homelessness in our cities is really important to recognize. And this slide here is just an illustration of that. This is a photograph of the city that I was born in, Los Angeles. And as many of you may be aware, there are massive encampments of people. There are tens of thousands of people who are homeless in the city of Toronto, in the county of Los Angeles alone. And I think on reflection, we realize that this can't be because Los Angeles County has a higher prevalence of mental illness or substance use than any other city in the country. It's because of structural forces that are causing this high level of homelessness. And this is illustrated in this figure that shows a comparison of homeless counts among various major urban centers. And I apologize, this slide is created in Toronto, so that's why Toronto is highlighted in yellow. But you can see that if you look at the number of people who are homeless per 10,000 residents, there's a dramatic variation from city to city in the US and across cities in Canada. First of all, you can see that the rates are much higher in the US than in Canada. And even among Canadian cities, there's up to 5-fold variation. So again, this illustrates the fact that while there are individual level vulnerability factors, it does not mean that homelessness is an inevitable problem. The prevalence of homelessness is determined by how we structure our cities and how we structure our society. So how does homelessness affect health? This is obviously a really multidimensional problem, but it's obvious that when people are exposed to extremes of cold or heat, that can affect their health, that the social environment of homelessness increases the risk of violence and victimization and also increases the availability of substances so that people who had substance use problems develop worse problems and those who didn't have substance use problems often are introduced to them. There's exposure to infections of various types. There's the adverse effect that it has on mental health and the development of depression and hopelessness. The lack of an environment for wellness and for recuperation from acute illnesses, and the fact that it impairs access to healthcare and creates stigma and discrimination that really can form a barrier to improved health. So how can we address this problem? I'm going to start with 4 practical tips to improve the care that you provide for hospitalized patients who are unhoused. And these are 4 things that you can apply every day in your practice. And I actually believe that they are relevant not just to people who are homeless, but to many patients who are experiencing disadvantage and who are been marginalized in our society. The other thing I'm going to point out here is that I'm a general internist, and none of these tips relate to some secret medical treatment or some different way of the technical kind of aspects of the practice of medicine. This is about how we provide care. And they are, first of all, focusing on the relationship. Secondly, understanding trauma. Thirdly, addressing substance use. And fourthly, addressing our goals. So first, focus on the relationship. So I'm just going to say that we only have one chance to make a first impression. And I think it's extraordinarily important when we take care of patients who have experienced homelessness and stigma and discrimination in many of their past encounters with healthcare providers. And we just need to remember that for many of our patients who are homeless, they come into the hospital expecting to be treated really badly. Literally, they expect to be treated like crap. And I think our goal is to exceed those expectations by orders of magnitude. We really need to take the time to explain what we're doing and why we're doing. And I'm just going to give you a quote that I think really helps me think about how to focus on the relationship, our relationship with our patients. The poet Maya Angelou once said, I've learned that people will forget what you say. They may even forget what you do, but they will never forget how you make them feel. And the question that I often ask myself is, how am I making my patient feel? And if we focus on that, then that often will help us provide the kind of care that they need. Secondly, we need to understand trauma. So many of you are already familiar with ACEs, or adverse childhood experiences. This is something that's been extensively studied. And we know that ACEs, such as the ones shown on this slide, are highly correlated with subsequent physical and mental health in adulthood, and a whole host of outcomes. They're associated with premature mortality, they're associated with healthcare utilization, with economic success. And so when we look at these adverse childhood experiences among people experiencing homelessness, what we see is that the prevalence of one or more of these adverse experiences is 90% among people experiencing homelessness, which is twice that of the general population. And when we look at those people who've been exposed to 4 or more adverse childhood experiences, and I'll just show this again. So just imagine growing up being exposed to 4 or more of these kinds of experiences. And what we see is that 54% of people experiencing homelessness have had 4 or more in their childhood. And that's a rate that is 10 to 20 times higher than that of the general population. So it's just really important that we provide trauma-informed care to our patients who are unhoused. We have to really focus on creating physical and emotional safety for them, to realize that these are individuals who have often felt completely out of control in their lives and having no choices or control, and that we need to really grant them that choice and control in decision-making as we work with them during their hospitalization, and that we avoid re-traumatization. There's a very nice resource here that gives you just a brief summary of how to practice trauma-informed care, and it can be done in like 30 minutes. So I just recommend that as a resource for people that like to learn more about that. Thirdly, we need to address substance use. And I realize this is a no-brainer, but I think that we really often don't do this as well as we should. So we really need to be proactive about this and reassess our patients' needs frequently. And I'll just share a couple of examples, like a couple of things that I've seen in my practice go awry. So cigarette smoking is actually something that often causes challenges when our patients are in the hospital. We will often prescribe nicotine replacement therapy, but actually I find that that is only occasionally helpful. And it is quite often that patients will leave the ward frequently, especially during these times with COVID. It's a problem, and the staff are often up in arms about this and are asking us to, stop the patient from going out. Or sometimes patients will leave against medical advice because they can't smoke. And really, I find that allowing or facilitating patients to go out to smoke can actually be very helpful to facilitating them to stay for long enough for their acute medical issues to be addressed. Alcohol use is, of course, a very common problem, and I don't know if you have the ability to provide managed alcohol at MUHC, but certainly we found this to be a very useful approach at our hospital, when we can, for the patient who has no intention of stopping drinking and who is a heavy alcohol user, and for whom alcohol use is not their primary reason for being in the hospital, we will often allow them to drink while they're in the hospital, and that often will result in better outcomes. And then lastly, a word about opioids that we all know have really just ripped through our society and have ripped through the homeless population over the last few years. I just want to put up this slide to really just remind us about what a serious challenge we're up against when we admit patients to the hospital. So our patients may say stuff like, "Oh, I use 3 points of fentanyl every day." And actually, most trainees that I talk to will say, "Well, I don't even know what that means. What's a point of fentanyl? What does that really mean anything?" So a point, and I just want to credit this to a pharmacist at our hospital, Kelly Sequeira, who actually provided this kind of pocket calculation. So 1 point refers to 1/10 of a gram or 100 milligrams of substance as it's sold on the street. So when someone buys a point, it's 100 milligrams of a substance. Now, the question is, of course, what is that substance? And this varies tremendously from city to city and from time to time. So I only have data from Toronto, so I don't know if you have data in Montreal, but currently street fentanyl at the time that this was done, and it's a few months ago, was 4.4% fentanyl, but highly variable. Of course, which is what accounts for the fact that people are overdosing and dying when they take what they thought was a normal dose of fentanyl. So what this means is that 1 point of street fentanyl, if it's 4.4% fentanyl, is 4.4 milligrams of pure fentanyl, which is, I think everyone recognizes, an enormous amount of fentanyl, which is approximately equal to 440 milligrams of morphine or 66 milligrams of hydromorphone IV. So it's just important to recognize that when we are taking care of patients who are using street drugs, that we are going to need to use what we might consider enormous doses of opioid agonist therapy in order to control the withdrawal. So it's just really important to ask about street drug use in a non-judgmental way so that people will disclose what they're using, to offer and initiate opioid agonist treatment, either Suboxone or methadone, and supplementing that with short-acting opioids as needed. Offering and providing harm reduction services, and we're currently in discussions at our hospital about the question of whether we can provide a supervised injection site within the hospital, and involving substance use specialists if they're available. I know that this has been a real challenge in many hospitals, and is something that I just think is just absolutely essential, and something that we should all have in every hospital, just like we should have, we have medical specialists in every hospital. We need to have substance use services in every hospital. And lastly, I would just say that we need to adjust our goals. As internists, we're often used to being the people who diagnose people and solve problems. And sometimes our focus on problem solving can perhaps blind us to the importance of being patient serving. When we're too focused on our patient as a problem that needs to be solved, we neglect the need to build that relationship and to serve their needs and meet them where they are. And I think that's really something that we can just keep in mind when we're working with patients who we find to be perhaps frustrating or challenging to work with. So moving on, I just wanted to talk about improving your healthcare organization. And this is something I'll talk about in the context of what we've tried to do at our hospital. So we all know that people who are homeless come into the hospital. We provide them with excellent care while they're in the hospital. But what happens is that sometimes they for the reasons that often for some of the reasons I've just mentioned, they leave against medical advice. And sometimes they complete their hospital stay and we discharge them with a follow-up plan, which promptly completely falls apart, and the patient will often come back to the hospital, will be readmitted, and will go like, oh, what did you do wrong? Like, how come you didn't do what we asked you to do? And we know from our research, at least at our hospital, that as many as 30% of people who are homeless and are discharged from our medical service will be readmitted within 60 days. So I'm just going to give you an example of an initiative that we've developed that it's not the answer for every place, but I guess I'm presenting it as an example of how we should try to think outside of the box of our usual clinical practice to try to better meet the needs of our patients who are marginalized and disadvantaged. And this is not only for those who are unhoused, but this particular intervention is specifically for people who are homeless. So we created something called a Navigator project for patients who are unhoused and admitted to St. Michael's Hospital, recognizing the challenge of connecting with people in the hospital, ensuring that they stay in the hospital and then follow up afterwards. We created a team of homeless outreach counselors who are specifically dedicated to working with people who are homeless in our hospital. And I should say, in our hospital, about 15% of the patients admitted to medicine, general internal medicine, are homeless. They engage with them while they're in hospital and help develop rapport, meet with them, kind of explain what's going on, buy them coffee and snacks if they need it, and connect with them. And then follow up with them in the community after discharge, helping to connect them to healthcare and other services such as case management and housing workers and other services, helping them to get to appointments with the goal of improving their experience of care, improving the process of care that they receive, and hopefully to improve health outcomes and reduce return to the emergency department and readmissions. So I'll just point out that we don't know if this intervention works yet. And so what we're doing is we've piloted the intervention with creating this team of counselors. And now, just 2 months ago, we launched a randomized controlled trial at our hospital to determine if it's effective in improving the process and care and health outcomes. And so if you're interested in learning more about this intervention, you can go to maphealth.ca/navigator to learn more about this intervention. This intervention is not necessarily what every hospital needs, but I think we need to think creatively about how can our organization better meet the needs of our patients? And it's going to need to be tailored to your community and your patient population. So I'm going to move on now to the question of shouldn't we be thinking about the social factors that are driving the problem of homelessness? And obviously, homelessness is a housing problem. So the question is housing the solution to the problem of homelessness? I'm going to show you the results from this, the effects of a housing first intervention, essentially the provision of immediate access to housing using a rent supplement, together with intensive supports to help the person make the transition from homelessness into housing. And these are results from the at-home Chez Soi study, which was conducted in cities across Canada a number of years ago, including in Toronto and Montreal. So this graph shows you the results of the Housing First intervention on the left-hand panel, high needs individuals, and on the right-hand panel, moderate needs individuals. The red line shows the people who received the Housing First intervention, and the blue line shows the treatment as usual group. The y-axis shows the percentage of days stably housed in each year of follow-up. And this time scale actually goes from 1 year to 6 years post-randomization. So what you can see is that in both the high needs and moderate needs individuals, this approach, the Housing First approach, was very effective in ending homelessness and that this effect was persisted over the 6 years of follow-up. And that the differences among the groups, while they lessened over time, persisted. So this slide essentially shows that the Housing First approach is a effective and durable way of ending homelessness for people, many of whom are chronically homeless. So we might look at this slide and say, as physicians, great, so we should do this for everyone, and this will solve all the health problems that we're addressing in people who are experiencing homelessness. And however, when you look further at the results of this study, looking at various other outcomes, we see a bit of a mixed picture here. So among this is looking at the effect of the Housing First intervention on change in use of healthcare over 7 years post-randomization. I'm just highlighting 3 healthcare indicators here: the number of hospitalizations, the number of days in hospital total over the follow-up period, and the number of ED visits. And we're looking at the rate of change in the housing group compared to the rate of change in the usual care group. And what you can see is that in the high needs group, the housing intervention, which was very effective in ending homelessness, was also very effective in reducing not the number of hospitalizations, but the number of days in hospital with a relative rate ratio of 0.32, and reducing the number of ED visits by a rate ratio of 0.57. I should point out that the rates of hospitalization and ED visits actually declined in both groups over time, but what this shows is that they declined more in the housing first group. Excuse me. What we see in the moderate needs group, however, is a different picture. These are individuals who had less high mental health needs. I should mention that these were all individuals who had serious mental illness. But in the group who had less severe needs, we did not see a reduction in the number of days in hospital or ED visits. And in fact, we saw a significant increase in the number of hospitalizations, perhaps reflecting the fact that when you provide more care to people or more attention to people who are not receiving a lot of services, that in fact, sometimes that results in an increase in healthcare utilization. So I think this slide overall shows that while housing does have some significant, does result in some significant decreases in healthcare utilization, it can also have the opposite effect for other groups. And so going back to the slide that showed the great effect of this intervention on housing outcomes, what we did is we also looked over the long term on other well-being outcomes, such as quality of life, community functioning, and substance use. And what we found, and I'm not going to show you pictures for this, but what we found was that the intervention group did not do significantly better than the usual care group, suggesting that while we were very successful in ending homelessness, and while we did reduce some indicators, some healthcare use outcomes, we didn't have an enormous effect on improving health in terms of certain health outcomes. And you might ask, so why did this happen? And I guess that there are 2 possible answers. One is that, we did not spend enough attention and time addressing health needs with healthcare focused interventions on top of the housing interventions. And that may well be true. But I think that the other thing is when we look at what the social determinants of health, and this is a complex diagram that just shows the web of factors that affect people's health, that, housing is simply one of the material circumstances that affects people's health over the life course. And, I think that perhaps we should reconsider the simplistic idea that if we just end homelessness, that will improve people's health and well-being automatically. That we really have to look at the larger picture and also at the impact of years and sometimes decades of inequities and deprivation that people have suffered from. So just to again illustrate this, I think that we're all can understand very simply that there's this vicious cycle that individuals who have either poor housing or no housing will lead to worse health, that people with poor health are actually likely to end up homeless, and thus the cycle kind of is one that needs to be broken. But what we sometimes don't realize is that this is a downstream approach to looking at the problem of homelessness. And if we think upstream at the more societal causes, that this whole problem can be situated within the larger impact of poverty, which is the ocean that we are swimming in when we're talking about this problem. So the inequities that impact people and populations over a lifetime are something that, you know, it's all around us all the time, or all around them all the time. And we sometimes focus on the immediate circumstances of the person without recognizing the larger problem that has really kind of within which the issue of homelessness is situated. And so I'm going to close with this slide, and I'll explain to you why I'm going to close with this slide. This is a picture of a river in China, and obviously situated on a large city. And one day the river, and I don't know if you can see it, the color of the river turned from its normal color to blood red. And of course, you know, one response of the healthcare providers in this city might have been to say, oh, well, we should warn people that, you know, don't drink the water and don't go swimming or contact the water. And we should figure out, you know, if people are being poisoned or having reactions to it, that we need to like figure out how to treat them. And we should prepare our healthcare system to deal with this problem. But if you think about it, while that is important and necessary and good, the problem does not lie in the city. The problem is upstream. And if we as healthcare providers only focus on the individuals who are sick before us right now and never think about the upstream forces that are driving the problems that we see, we will continuously be fishing people out of the river, metaphorically speaking, and treating the problem that really is located upstream. And so I'm just going to end with the suggestion that we as physicians or future physicians need to think about our role or our potential role as powerful advocates for structural change on the social determinants of health. We are actually very, very blessed and privileged people. We have a very privileged position in our society for a number of reasons. First of all, you know, we are fortunate to be called to a profession where our calling is to attend to the health of individuals and populations, to really think about how we can help others. Secondly, we have the trust of the population, and we have expertise that we can use to improve the social determinants of health and to speak out as advocates. And lastly, we are among the 1% of privileged people in our society. We are truly, you know, we are wealthy and blessed, and we have the ability to do this. So I think that as physicians, we should really be thinking about how can we act as advocates on the social determinants of health, and not think just about what we can do for our individual patients, although that is very important, but how we can look at the issues that are driving illness in our society. And it may not be homelessness and housing, it may be childhood well-being and education in our schools. It may be the health of Indigenous people across this land. It may be, you know, around issues of addiction. But, you know, I think that we have to find our voice and recognize our potential strength as advocates. So I'm going to just end there and thank you for the chance to speak with you. That's my email if you want to contact me, and that's the website of our research center. I'm going to stop sharing my slides, and I will be happy to answer any questions.
Thank you so much. Really fascinating topic. I don't think I've heard a lecture on this topic before, and I think that's fascinating. And congratulations on the work that you're doing. I dare say that we're quite far behind here in this regard. We have quite a few questions, and because we have time, I'd like to kind of open it up a little bit for discussion. So I'm going to ask Sasha Bernatsky if you want to verbalize your question and open up the discussion.
Sure. So I think you actually started talking about this a bit at the end in terms of do we actually have to tackle this at the point of when someone's a child, because I think maybe what ends up creating homelessness does begin a lot earlier than we imagine. But you probably more than any of us understand the different mental health challenges. I think so some of us might have the concept that it's, obviously somebody who's schizophrenic and we see them mumbling to themselves on the street, but that's only one part of homelessness and you referred to addiction and mental health. So are you currently, have you already identified where mental health could specifically be? If we begin with our encounter with people in the hospital, are there opportunities where we could or should intervene? And is that where you're going with the mental health part of it? And then is there a link with addictions perhaps there, that if you could help address some of the underlying, do people use illicit drugs to sort of treat illicit drugs and maybe alcohol even to treat some of the mental health, the untreated mental health issues? It's are they so much intertwined, and are there efforts that you can conceive that would help regarding mental health?
Yeah, so that's a great question. I mean, I think that from the perspective of, and so I should just mention, I work both in the hospital on general medicine and in the community in the shelter. So I kind of see both sides of the issue. That it's really, when we work in the hospital, what we need to realize is that, the real challenge is the long game. It's not what we do while the patient's in the hospital. It's our ability to connect them to the right addiction, substance use treatment and care, and mental health care in the community. And that's something that we often do very poorly. It's not like we have it figured out here. What often happens is that we need to have a system in which we connect people to the care that they need in the community. Ideally, a warm handoff where they meet the person while they're in the hospital, because the problem is it's all about trust and relationships. So, to say to someone, go see this person who you've never met in this place you've never been to before is going to be really tough. So I think that trying to build those bridges between community mental health and substance use providers and the care we provide in the hospital, so it's not like siloed, is really important. So I just think that, and that's something that we are trying to do, but it requires a lot of, coordination and collaboration.
Thank you. Ariane, Dr. Morelli, you have a question. You want to just ask it, please?
Sure, thank you. Thank you so much for this very provocative and thoughtful presentation. So I wondered if you could help us think about the ethics of actually having to modify our intention to provide guideline-driven care when we know that after the intervention, as a cardiologist, for example, we know that if the patient is unable to comply or go to follow-up appointments, the intervention will fail. So, I'm thinking about, putting in ICDs or dilating coronaries and having patients go out on dual or triple antiplatelet therapy. And we know that these patients absolutely must have the right follow-up. And so we're kind of stuck sometimes because we're just really torn with that ethical dilemma. How do we, decide to withhold care because we know that the long-term follow-up or even the immediate sort of intermediate follow-up will just not be adequate beyond hospitalization?
Yeah, so that's a great question, and it's one that we've struggled with, and I've worked with cardiology colleagues who've basically voiced the exact same kind of concerns and challenges. I think that, I guess that I don't view it as so much, I think that the challenge is not so much an ethical one, because we always try to do what's best, but we also have to realize that sometimes it's questionable whether it's going to be feasible. And to me, the question, first of all, is there some way to make what is best feasible? And you know, rather than saying, oh, this person who is homeless, we know they're not going to adhere to therapy, is there some way to work with them and the people that they see every day and trust in the community, because often they do have those people, to make it work. And sometimes that is possible if we don't say, well, look, we've got this way to do things, and if you can't adhere, then it's a no. If we can try to figure out a way to make, for example, adherence possible with extra effort on our part or by collaborating with people in the community. Having said that, I recognize that sometimes we will provide less than, optimal care based on guideline recommendations. And I mean, that comes with the territory of working with people who live under less than ideal circumstances. I think that is like, we're feeling the moral tension of that. But I think that's actually, that's the result of working in an imperfect world. And I guess all the more reason to try to figure out a way to address it. But I don't have an easy answer to that question. I guess that all I can say is that sometimes we have found ways to work around what we thought were insuperable challenges.
Thank you very much. Thank you. Tina Padima, would you like to ask your question?
Yeah, hi, Stephen.
Hi, Tina.
It's been a long time. It's really nice to see you. And thank you so much for your beautiful, beautiful, compassionate talk. You're probably the person in Canada that knows most about homelessness with Jeff. And many years ago, we wrote a paper on managed alcohol in Ottawa, and Stephen was like the best editor in the world for that. And I just was going to comment that in Montreal, in the old Royal Victoria Hospital heritage site now, a managed alcohol project was just opened earlier this year, I think in January 2021. I'm not involved with it, but I just was going to comment that there was a project that had opened up in, sort of in our old home and the old site of the Royal Victoria Hospital. And so I don't know how that project's doing, and it reminds me to sort of try and check back and look in the literature and in the media to see how it's going. And so again, thank you so much, Stephen, for your beautiful talk.
Thank you.
Thanks. And I just want to mention, I think there's a lot of interest in the audience and on my own part about the managed alcohol program. So if there's anyone we can connect to hear details about it, that would be great.
Terrific. Stephen, and then Suzanne. Stephen, you have your hand up. Do you have a question for us?
Sorry, did you mean me?
Yes, Stephen Grover.
Grover, yes.
I really enjoyed your talk too. I have to confess, after all the years I've been going to grand rounds, I've never heard anyone focus on this particular topic, and I think it was long overdue. I have a question for you. I was taken by the fact that you guys or your collaborators were ambitious enough to try and do a randomized clinical trial, and I really think for so much we do in healthcare, in academic healthcare, randomized clinical trials are just an overreach, and there's no reason we should expect that outside of a particular tightly focused clinical problem where there's a drug or some very focused intervention that we should ever expect to have any conclusive results. I wondered if you've thought at all about other ways to approach this from an academic perspective so that you can somehow capture the benefits that are associated with the various interventions you're trying, but not set the bar so high that you're going to try another clinical trial.
Thanks, Dr. Grover. So that's a great question. I think that, as clinicians, we all know that, randomized controlled trials are great for some things, but, if we tried to do everything based on an RCT, then we would be doing a lot of trials that we would think are kind of either inappropriate or not worth the effort, or kind of like applying the wrong approach. in homelessness and in the work that social, I guess, determinants of health, there is a value to doing RCTs. And I think that kind of identifying, in my mind as a researcher, identifying the selected questions and that need to be answered within RCT, and that are, where it's appropriate and worthwhile, is really a good skill. But as you've pointed out, it's also important to recognize when it's more important to just do something and kind of evaluate in a non-randomized way, like, is it having an effect? Does it appear to be, acceptable? Is it getting engagement? Does it have, is it resulting in changes that we think are meaningful? And this is, for example, the approach used in the evaluation of managed alcohol programs, which have never been subjected to a randomized controlled trial, but which, for those of us who have been involved in them, we have no doubt that for the right people, it makes a huge difference. I guess that I would just say that, I do love RCTs, because I think that when you're asking policymakers to invest a significant amount of money on changing the way things are done, in terms of not just healthcare interventions, but social policies, it's powerful and sometimes very needed evidence.
Thank you so much. We have a few more questions, so maybe 2 minutes per question coming up. Suzanne, you had your hand up.
Thank you very much, Stephen. This was a great talk. Basically, my question revolves around the RCT you have just started recently, and in terms of how these homeless outreach counselors that you've mentioned. So the question I have mostly is how you actually identify or select these people, and do they have some kind of link with the community or the particular group or population of homeless people that you are trying to reach? So for example, near the Montreal General Hospital, for example, there's a large population of Indigenous people who are homeless, whereas in a different part of the city, it might be a different group or different populations. So do you try to match your counselors with the population you're trying to reach?
So it's a great question. So the program has taken years to kind of get to where it is now. So we actually took us almost 2 years to just kind of come up with a concept and then hire the right people. I should just point out there are only 2 of them, but what we did is we didn't look for health professionals. We looked for people that had the right skills, which was essentially people who really knew the community, knew how to work with people who are homeless, and who were willing to basically kind of do what was needed. They were highly connected people. Like, basically, they're the kind of person where if you said, there's this guy who we've admitted, and he says he hangs out at this place and we don't really understand where it is, and one of our counselors would say, oh yeah, I know that place and I know the person who works there, I'll just give them a call. And they're highly connected. Their skills are particularly in the community, but what's also essential is that they are actually hired by their hospital staff. So they have full privileges, just like any nurse, to like walk into the patient's room and say, hi, I'm here as part of the healthcare team. How can I help you? And so it's that kind of rooted in the hospital, but really well connected in the community. And to answer your question, of course, there's diversity in the population that we serve. And you can't have someone that is like, I guess, specifically skilled to serve just one population. So having people who are like kind of multi-talented and who can work with anyone is really a key.
Thank you very much.
Fantastic. Molly, are you able to ask your question?
Yes, sorry, I had to go on mute for a minute. So thank you for a really great talk and something that's been near and dear to my heart for a while. So, I look after the sickle cell population and the hemophilia population, some of the rarer things. And what I find in our adult population is within the adult milieu, we do not have access to allied healthcare members of the team who are crucial to help us with this. People like social workers, people like patient navigators, etc. And so my question is, do you easily have adequate access to those resources in Toronto? Because right now in Montreal, what we have to do is send these people out to their local CLSC, to a social worker who has no kind of appreciation of what any particular disease may cause or happen or interfere with family and work life and school life. So do you have access to those things in your area within outpatient clinics?
So it's a great question. I think I would have to say that, we have very constrained resources here as well. And, often there's not the allied health support that is needed. I have to say that a lot of the work that we do is made possible by fundraising. So, and that's why, it's, I have to say that I'm partly a scientist, but I'm partly a fundraiser. And, a lot of times the pitch is that, first of all, that these are, and I think, the COVID pandemic and the what has happened over the last couple of years has really, I think, brought to the forefront the inequities in our society and the importance of the issues of health inequities and health inequities. Yeah. So I think there's more receptivity to the problems that need to be addressed.
Okay.
I think that, again, the idea that we evaluate our interventions. So we're not just saying, just let's fund this service and we'll just keep doing it, but that we're going to try to measure the impact and demonstrate whether it's effective or not is very important as part of and that's part of what we do at MAP.
Okay, so that was going to be my next step with disease-specific quality of life outcome measurements and so on. So thank you very much for the answer and a great talk.
One last question. Ingrid Hings, are you there? Can you ask your question? This will be the final question. Ingrid, are you there? Okay. Well, if not, then I'll let her her answer. Her question is also in the chat, so I'll let you, Dr. Hwang, answer that.
I'll read her question. So her question says, what kind of community partners did you collaborate with, i.e. homeless shelters and food banks? So, yeah, so actually I to do this kind of work, it's absolutely essential to build collaborations and partnerships with the community who often people and to find the right partners, but often people in the community understand the problems as well or better than we do and have kind of are just eager to connect with someone within the kind of the forbidding walls of the hospital that are interested and willing to engage with them. So I think that making that time is important. We, in the course of our work, we engage with shelters, we work with housing providers and with, the places that operate the shelter hotels in Toronto that used to be hotels, but are now temporarily housing people who are homeless. So absolutely. And I have to mention that one of the other things is never underestimated, at least in my experience, the fragmentation of the system, so that, you can have literally two organizations that are essentially working side by side, but don't really coordinate what they're doing. And it's really important to create those relationships where people can figure out what each group is currently doing and try to improve the collaboration among them rather than kind of doing it in a siloed way.
I'm going to say, first of all, it is 1 o'clock, so we're going to have to end the session, but a great thank you on behalf of the Department of Medicine for this wonderful lecture, thought-provoking, and really congratulations on all this terrific work you're doing. And I hope we can have you back here next year or the year after to tell us more about how things are going. So thank you. Suzanne, do you want to say a last word?
Yeah, no, again, I think everybody was very engaged. I'm very pleased that you accepted to come and discuss, or come virtually to discuss this with us. I think it's been really great. Thank you.
Thank you for having me.
Thank you. And thanks everyone for all your discussion. And it was a fascinating hour. Thank you so much.
Bye.